Welcome to the webinar entitled State-of-the-Art Diagnosis of APCR. And now let's get started with the webinar. Our speakers today are Dr. Colin Murphy and Dr. Florian Pruller. Dr. Murphy is an assistant professor at the University of Maryland School of Medicine in the Department of Pathology. He is a transfusion medicine physician boarded in anatomic and clinical pathology with a background in trauma and coagulation research. After completing a Doctor of Medicine degree at Indiana University, Dr. Murphy trained in residency at the University of Washington and completed a fellowship in transfusion medicine at Stanford University. His published work includes research on antiphospholipid antibodies and lupus inhibitors, the acute coagulopathy of trauma, and visualizing and predicting institutional blood use. Dr. Pruller studied medicine in Graz and Poznan, Poland. He wrote an experimental doctoral thesis addressing neurotrophic effects in chemotherapy-induced neurotoxicity. He trained in family medicine in hospitals in Nigeria, the United Kingdom, and Styria, and became a chief consultant in laboratory medicine at the University Hospital Graz. There, he established platelet function testing and arranged several key projects on hemostasis, harmonizing oral anticoagulation therapy monitoring in Styria, and modernizing viscoelastomeric coagulation monitoring. Dr. Pruller has been published in high-ranked journals on topics related to APC resistance, factor V Graz polymorphism, endogenous thrombin potential, and beta-D-glucan testing. Our experts will discuss clinical experience with and benefits and limitations of phenotypic APCR testing in Europe and the US, and how it compares with genotypic assays for this mutation. We'll start with a presentation by Dr. Murphy, followed by Dr. Pruller, then we will have a question and answer session. Now I'll pass it on to Dr. Murphy to start.
Thank you for that introduction. As mentioned, my name is Colin Murphy. I'm assistant professor at University of Maryland in Maryland, and I'm an assistant medical director for the Transfusion Medicine Service at the University of Maryland Medical Center. For those of you who don't routinely work with transfusion medicine physicians, we're expert consultants on when to give blood products for patients with both bleeding and clotting issues, and spend a lot of time working with surgeons, anesthesiologists, hematologists, and other physicians evaluating the risks of bleeding and clotting. So I think a lot about the balance in coagulation between those two things. Today, we're going to be spending a lot of time focusing on the clotting side of that balance, talking about venous thromboembolism. Now, where I practice in the United States, venous thromboembolism is one of the most significant causes of morbidity and mortality. Classically, we're taught that there's a triad, known as Virchow's triad, of precipitating factors that can lead to a venous thromboembolism: endothelial damage, venous stasis, and thrombophilia, or an inherent predisposition to forming a clot. Some factors that result in increased risk of clotting can come from outside a patient. Things like surgery or immobilization resulting in venous stasis or endothelial damage, or long travel, although not as many people have been having long travel recently. Hopefully that will pick up. Endogenous risk factors coming from inside the patient can be temporary, like pregnancy, or what we're focusing on today can be permanent, inherited thrombophilias, inherited differences that result in a patient having a lifelong tendency to clot. The most common inherited thrombophilia in the populations we test is a mutation in factor V called factor V Leiden. Factor V is normally broken down by activated protein C as part of regulation of the coagulation cascade. As there are procoagulant forces, there are anticoagulant proteins like activated protein C that serve to regulate, make sure that when clots happen, they happen appropriately in the right time at the right place. If you have an aberrantly resistant factor V that can't be broken down by activated protein C, that means that you've shifted the balance toward an increased risk of clotting. Factor V Leiden is the most common mutation that we see in our population that leads to activated protein C resistance. And once you have tilted that balance towards an increased risk of clotting, then you have an increased lifetime risk of clotting and venous thromboembolism. When patients are screened for factor V mutations like factor V Leiden, that screening can either be genetic or functional. The genotypic testing is some kind of sequencing or PCR amplification with fluorescent detection, and it is mutation specific. It's only looking for the factor V Leiden mutation specifically. functional testing is looking at what's present in the patient's plasma. Do they have activated protein C resistance? The way that this is done is two coagulation tests. The first one, we take your patient's plasma and we add something called a factor V dependent prothrombin activator that works directly with factor Va to catalyze the formation of thrombin from prothrombin, leading to a clot. So we take your patient's plasma, add that factor V dependent prothrombin activator, and time the amount of time it takes to make a clot. Then we do that exact same test, but we add activated protein C that's a reagent that we keep in the laboratory. If your patient has a normal or wild type factor V, then when we add the activated protein C, that will break down their factor V, resulting in a profound prolongation of the time it takes to clot, because there won't be any factor Va to work with the factor V dependent prothrombin activator. You can see here on the right, there is a graph with the y-axis labeled as ratio, and that's the ratio of the APC added clotting time to the non-APC added clotting time. With your wild type, that's going to be extensively prolonged, so that ratio is high. If you have activated protein C resistance, when we add the activated protein C to the reaction, your patient's factor V will be resistant and it won't be broken down. And so that ratio will be much closer to 1. So this is the background to us discussing the research I did when I was at University of Washington, Seattle, comparing a phenotypic or functional activated protein C resistance assay with a genotypic assay. This was published in the American Journal of Clinical Pathology in 2019. This is an aerial view of the University of Washington, Seattle, with the Montlake Cut in the background. Seattle is a very, very beautiful city, provided you are lucky enough to be there when it's not raining. So one thing that University of Washington had that was really advantageous for doing this study was an electronic data warehouse, or a repository of every result we ever generated for our coagulation testing. University of Washington is a reference laboratory, a fairly large one. They see a lot of business from the Northwest United States and a lot of other hospitals across the country. And so this meant that they had a large number of coag tests that we could peel through. What we ended up doing is trying to identify all patients who had had both a functional activated protein C resistance assay and a genotypic factor V Leiden assay. We have some thoughts on whether it was necessary for people to order both, but this was a sample of convenience. Since we were looking retrospective, we were able to identify folks that had both done. And we were able to pull up almost 1,600 patients who had had both the functional and the genotypic tests ordered by their clinicians. Now, this study duration was 10 years, and one product of that is that over time, things change, methods change. And early in the study period, for a period of about a year, we had been using a different methodology for the functional test. We've been using a partial thromboplastin time, not terribly different from the process I described earlier. Just instead of using the factor V dependent prothrombin activator as the way of generating the images for the clot, this method was doing 2 partial thromboplastin times, one without activated protein C and one with activated protein C, and the same process of taking the ratio of the two, and if it's higher, that suggests you have a normal or wild type factor V. The advantage here is now not only can we compare the functional factor V dependent prothrombin activator assay and the genotypic assay, we can compare 2 different types of functional assays to each other into the genotypic assay. So overall, for our 1,600 patients, we had really strong concordance, complete concordance in 1576. That included 6 homozygous patients, 167 heterozygous patients for factor V Leiden, and 1,403 negative patients. 20 cases were not concordant between the functional assay and the genotypic assay. The bulk of those, 55%, were equivocal assays, where the ratio of the non-APCR to APCR clotting times was in between or too close to call. 3 assays had some flavor of interference. There are not as many interferences for the factor V activator assay, but things like direct thrombin inhibitors can interfere. And there were 6 potential discordances that we investigated using chart review to determine if they were due to the assay or due to something else in the patient's clinical history, which we'll get to last. Let's start by diving in for the partial thromboplastin time, or PTT-based functional test. Like I said, we had about a year of data here, so there were only 281 total tests that we compared to the genotypic assay. But for an older test, I would say the PTT performed pretty well. one thing that we noticed is that 8 of those 281 were equivocal, right? I mentioned 11 total earlier. Well, 8 of those 11 equivocal results occurred during the PTT era. That means about 3% of them were equivocal, which is a pretty decent chunk. The biostats here still look pretty good. There was one case that we felt was not adequately, discrepant case that was not adequately explained that results in this not having a perfect sensitivity, but very good specificity, positive predictive value, negative predictive value. You should compare this with the factor V dependent prothrombin active era. We have a lot more tests here, over 1,300. Only 3 of 1,300 were equivocal, which is a rate of 0.2%, an order of magnitude less than the PTT era. And the biostats here are pretty much perfect. They're as close to 100% as we could expect. There's pretty much perfect concordance between the functional and the genotypic assay here. The discrepant cases give you a good insight into what I would consider the additional information you can get out of a functional assay in certain patient populations. A really good example would be case 2 here, where the functional assay was negative, but the genotypic assay predicted that the patient was heterozygous. On chart review, it turns out this patient had had a prior liver transplant, and so it is highly likely their liver transplant came from somebody who had a wild type factor V. And so their liver transplant, which was given for other reasons, was also potentially curative of their factor V Leiden. Case 5 is illustrative in the opposite direction. This was a patient who has functional assay was positive for activated protein C resistance, but their genetic assay was negative. Chart review showed they had a prior peripheral blood stem cell transplant. For those of you who are not laboratorians or working closely at laboratory medicine, you may not know that when you send peripheral blood for genetic testing, the genetic material we use comes from peripheral leukocytes. And in a patient who's had a prior peripheral blood stem cell transplant, some or all of their circulating leukocytes may not be theirs. It may be engrafted leukocytes from their transplant. There are subtleties to the way this works, but we believe in this case that the plasma assay, the functional assay, gave a much better picture of what was going on in the patient's plasma than the genetic assay. There was one case during the PTT era where the functional assay was negative and the genetic assay predicted heterozygote that didn't really have a good explanation. The patient didn't have any history of a transplant or massive transfusion, and they had an unprovoked venous thromboembolism event, which is why the biostats for the PTT era were a little bit worse. There was another case, but differently in the opposite direction, where the functional assay was positive and the genotypic assay was negative during the factor V dependent prothrombin activator era, in a patient with an incredibly strong family history of a blood clotting disorder. This was someone who had multiple primary relatives who had multiple events of venous thromboembolism. This we felt was potentially explained because although factor V Leiden, which is what we were doing the genotypic test for, is the most common factor V mutation in our population, there are many cataloged mutations in factor V that can cause activated protein C resistance that I believe Dr. Perler will be talking about, one at least in the following presentation. So what did we take away from this? We first and foremost took away that the functional testing is extremely accurate for detecting factor V Leiden negative and heterozygous individuals. It's really good for screening. Although we have less data on homozygous individuals because we only picked up 6 during this testing period, in part because homozygous factor V Leiden individuals are rare, but we identified all 6 out of 6 correctly on functional testing, which I think bodes really well for the accuracy of functional testing for homozygous individuals. Functional testing is more informative for patients who have undergone some flavor of stem cell transplant or a liver transplant. Because of the issues I mentioned on the previous slide, you're going to get a better idea of what's going on in their plasma versus the genetic test. And finally, a factor V dependent prothrombin activator-based functional method was an order of magnitude less likely to give you an equivocal result than the PTT-based one. And that's a difference of 3% to about 0.2 or 0.3%. Now, for those of you who only order a few of these tests, that may not seem like a lot, but if you order hundreds or thousands, or if you're part of a reference laboratory performing thousands of these tests, that's the difference between 30, 300. That can be a lot of patients that you have to call back, patients that you have to draw again. And for us as a reference laboratory, it was a clear win that we'd switched to the factor V dependent prothrombin activator method over the older PTT-based method. So test costs are tough to pin down, but in our environment, the phenotypic test or the functional test was much, much, much cheaper to perform than the genetic test. And so we had already been doing this, but this cemented our recommendation that providers who were doing initial screening for thrombophilia, which in our health system was performed in the outpatient setting, should use the functional test. They should use the activated protein C resistance test. It's cheaper, it provides the same information. We thought that was generally a strong recommendation before we did the study, and this only bolstered that recommendation in our eye. So with that being said, there will be some time for questions if you have questions after the next presentation. At this point, I'm going to turn it over to Dr. Pruller, who can take over and give his portion. Thank you.
And I welcome you all to my presentation. I'm doing laboratory medicine, and I will give you an overview in short how the coagulation works in general. Some overview about the physiology of protein C, factor V Leiden, and a certain combination of other mutations, as already mentioned, then some laboratory diagnostic aspects, and an overview. But to start with, I just wanted to say, or to show you where I'm at the moment, because I think some of the participants will not know where Graz is, and it's actually in the middle of Europe, and it's the hometown of the white horses called Lipizzans. And the other thing most of you will know is Arnold Schwarzenegger grew up in the nearby village. So, but let's focus on coagulation testing. You see here the coagulation cascade, and we have two main factors, factor 10 and thrombin, which are also a key element of the assay we are talking about. Actually, coagulation cascade works a little bit different. We actually have the activated platelet in the center as a cornerstone, but the classical coagulation cascade helps us to understand our tests used in hemostasis, and one of the main, and which was actually the one also used to perform APC resistance testing, was the APTT, which you see here covers more or less the intrinsic and the common activation pathway, which is the basis of APC resistance testing, but as we will later see, was as a brushed up and gives us now an assay, or an assay is available which much better reacts only to certain conditions and is not influenced by, for example, lupus anticoagulants and so on. So what's actually going on, or why is protein C that important? Maybe some things are repeated, but normally, if there is no endothelial damage, thrombolumodulin catches activated thrombin, and this activated thrombin activates via an endothelial protein C receptor, protein C. And this activated protein C and the free protein S stop or inhibit factor 8 and factor 5. And in the 90s of the last centuries, APC resistance was described, and in those days, factor V Leiden was the first genetic change which explained this APC resistance. So what's happening in a normal blood under physiological conditions? Thrombin activates factor V by cutting this B domain out of there is a B domain, a linking protein domain, which is removed by thrombin, and we get the active form of factor V, which is a cofactor to this factor 10. And later on, to inactivate activated protein C, cuts are mainly in the A2 domain, and we see the inactive form when it's cut at this 506 position, and there are some rescue cut positions which back up the inactivating the system to inactivate factor V. And to give you an impression how the protein really looks like under physiological conditions, because sorry, I missed one thing here. You see this nose. If this nose, which is the factor V Leiden mutation, because you get a change and conformation of the protein, this activated protein C can't cut at this main position, and we have a backup rescue system at 306 and 679. To give you an impression of the protein, here you see the physiological structure where this main amino acid is here on the 506 position, and you can imagine this here with the red circle. There is this active site where the site where activated protein C can cut, and on the other hand, if we have the mutation, the factor V Leiden mutation, arginine is exchanged to glutamine, and this forms some sort of nose which disturbs the proper enzymatic activity of activated protein C, and factor V can't be inactivated in a physiological way. And then there is a third circle, which is actually the position of a protein change, which we will address during my presentation. But now let's address the detection method to maybe some form of repetition. But we use the patient's plasma in a so-called elimination phase. We remove factor V by activating factor V with the venom of a certain snake. This snake is called Russell's viper. This is a classical venom used, Russell viper venom. The function is to activate factor V, and if factor V is available in a second phase, in the detection phase, we add noscarine, the venom of the so-called tiger snake, Notechis cutatus, which lives in Australia. And this venom activates factor II, and in the presence of active factor V, it potentiates the enzymatic action of noscarine. So we will have a clot formation within 40 seconds. And in a second assay, we do this testing in parallel. We activated protein C. So we have the same situation. We activate in a first step factor V and add activated protein C. And this activated protein C inactivates, under normal conditions, factor V. And in the second step, the detection phase, factor V is now missing. And we have actually a slow action of noscarine. And this slow action leads to a prolongation of the clot formation, and it lasts minimum about 120 seconds and even longer to get the clot formation. And these two results are now divided. So we divide the result with activated protein C with the result without adding activated protein C, and we get a ratio of 3 and greater, 3, so that's up to 10. And in this result, we see that the patient has, also we can say that there is a normal, a physiologic factor V, and is inactivated as expected. So, and what's happening if this so-called factor V Leiden mutation is present? We go back to the known picture with our Russell Viper activating factor V. And this factor V Leiden, as you saw before, as I showed you before, can't be inactivated by is slowly inactivated by activated protein C. So we have again the situation that there is a lot of active factor V because of this factor V Leiden mutation, and the enzymatic activity of noscarine is boosted, and we get again results something between 40 and 100 seconds. And if we divide this now, we get results ranging from 1 to maybe 2.5. And we can easily discriminate between homozygous and heterozygous conditions. Yeah, and as pharmaceutical industry developed new anticoagulants, we have the problem, or there is always a discussion, is there an interference with this new oral anticoagulants? And we did some studies and found out that there is actually no proper influence, or that the influence of the new oral anticoagulants can be neglected. As you see here, all heterozygous, all wild type results, so all patients who are wild type for factor V Leiden have APC ratio results in this green area, and all the heterozygous results stay in an area below 2.5 ratio. And the similar work was done by colleagues from Italy and several others. And although all these works also show that there is no influence of the 10A activating drugs, or inhibiting drugs, sorry. Yeah, and now let's turn to a constellation which is not based on liver transplant. It was a young adolescent female. She was sent for testing before prescription of hormonal oral contraceptives and shows the following condition: an APC ratio of 3.3, a factor 5 activity a little bit reduced, also the same with the factor 5 antigen level. Also we have no APC resistance, but molecular genetic testing showed a heterozygous factor 5 Leiden mutation. So how can these results fit together? And we have a family history without any pathological findings concerning thromboembolic diseases. Yeah, we were wondering what's behind this story. It took quite some time to solve the problem, because actually her brother was about 5 years younger, so we could not do genetic testing, but we could look into the girl's history. We checked the mother. The mother has an APC ratio of 3.09, as let's say 3.1, which is physiologically, so there should be no factor 5 Leiden mutation. The same with the grandmother, and we also checked the pedigree of the father, which was also without any hint for a factor 5 Leiden mutation. And then we could analyze or check the blood of the brother, and he had the same condition, normal APC resistance and some borderline factor 5 activity, and actually reduced factor 5 antigen. So what's the solution, or what's the how to solve this puzzle? And finally, we could solve this problem. We did an analysis and found a second mutation, and I will go through this. In case of a heterozygous factor 5 Leiden mutation, we have, let's say here, the father has a wild type allele, and the mother has this factor 5 Leiden mutation. So we will have in the bloodstream, we will find factor 5. Half of the factor 5 of the present factor 5 can be inactivated without any problems, and there is about half of the factor 5 in the bloodstream which can't be inactivated properly. So, and in case we have a second mutation, as seen here, we have a constellation where, let's say, the father has a mutation in the A3 domain, which leads to instability. This factor 5 protein is not expressed. So we find in the bloodstream only reduced amount of protein, and this protein is resistant to activated protein C. And if we do functional testing, we get the so-called pseudo-homozygous condition. So we will find a factor V Leiden mutation, but the results give ratios of 1, which would be normally would be comparable to homozygous results. And in our patient, we had a constellation where the factor V Leiden mutation and the new mutation are on the same allele, leading to a physiologic constitution where we have reduced factor V protein, but the protein which we find in the bloodstream reacts normally to the activated protein C. So this can be can be physiologically inactivated, and in an assay as described, we get normal ratios, as ratios above 3. So this functional assay helps us, or gives us more information than standard factor V Leiden testing, because we get information about a pseudo-homozygous constitution, and we get information about pseudo wild type or the pseudo non-mutated constellations. So it's a little bit similar to the brake testing we do normally with our cars. Nobody would rely on the company's information that brakes in a car. We regularly test them, and it's similar with this assay. And we showed a few years ago similar, as we checked all our records, and we found about 8,000 data sets where we had the factor V Leiden mutation result and the functional assay result. And about 6,000 were with wild type factor V and a normal APC ratio, a ratio above 2.5. And we had these discrepant results, which were pseudo wild type and pseudo homozygous. Yeah, and actually this data show that actually the factor V Leiden testing, the genetic testing, is not really necessary, and you would save in this population about 2 million euros, equivalent to more or less the same as $2 million. And I will also show or turn on the legal consequences, because here in Austria we had actually a case where we had a 23-year-old female lady with a negative personal history and a negative family history, and she wanted to get a third generation hormonal oral contraceptive prescribed, and this was done by her gynecologist, and 4 months later she developed a gastroenteritis, and a few days later a severe thrombosis and pulmonary embolism, and spent 14 days in hospital. And then genetic testing was performed, and she was unfortunately homozygous for factor V Leiden. and her gynecologist was sued for for a compensation of about 6,000 euros, which is not much. But the consequence is, as actually this was published, unfortunately, it's only published in German. You would translate it, liability rules in obstetrics and gynecology, medical evaluation before prescription of a contraceptive pill, a case before the Court of Appeals. So this gynecologist was sued that his job, his proper job would have been to do testing for factor V Leiden, or at least APC resistance, because if APC resistance testing would have been done, it would have shown that there is a pathological result, and this lady would have not been put on this contraceptive pill. And that's why we do quite a lot of functional APC resistance testing here in Austria and in Styria, due to this legal consequences. And actually, it's also interesting. I searched for settlements which were performed in the last years in the US, dealing with contraceptives, oral contraceptives, and other devices used for contraception. And this shows in the last little bit more than 10 years, about $2.5 billion were spent by the pharmaceutical industries in settlements dealing with contraceptives, which is actually quite a lot of money, because there were quite a lot of discussions dealing with thrombosis, thromboembolism, and so on. Yeah, it's quite a lot of money. Yeah, and I think hope I didn't talk too long, but the take-home message is that the take-home message of today, in my opinion, is, of course, coagulation testing is more than PT and APTT measurements. And we have here an easy assay which can performed in an automated version on different platforms. The results are not biased by the currently used anticoagulants. The test is not influenced by lupus anticoagulants, and of course not by heparin, by low molecular heparin. And actually this assay, in my opinion, is a cost-efficient contribution, providing medical care at its best. And I say thank you, and thank you for your attention, and awaiting your questions.
Thank you so much to both of you. And Dr. Pruller, you didn't talk too long, so thank you again for both of your presentation, Drs. Murphy and Pruller, for sharing all the data and clinical experience to help guide practitioners on the use of phenotypic APCR testing. At this time, I'd like to introduce Dr. Martin Glauner and Dr. Michael Janssen from DSM to moderate the question and answer period. Martin Glauner is a biologist and member of the DSM research and development team, and Michael Janssen is a biologist and operates as an account manager in the coagulation diagnostics area. So welcome, Drs. Glauner and Janssen.
Yep. Thanks for introducing me, and thanks, of course, to the speaker for your interesting presentation. Question from the audience. Well, we took note that you said that functional testing is or can be more informative than PCR in certain cases, such as patients with liver transplants or stem cell transplants, or in the case of the presence of additional mutations other than factor V Leiden, or in the light of oral contraception. So the question is actually, would you say that functional testing alone is sufficient, or are there cases in which actually both pathology is functional as well as PCR should be performed? Basically, the question to both of you.
Dr. Pruller, I guess I can take a first crack at that one. It sounds like, I'll just repeat the question to make sure I got it right. They're asking, are there cases where we would feel comfortable recommending functional testing alone, or should it always be paired with genotypic testing? I think that there's not a lot of society guidelines on this. You'll find plenty of society guidelines on whether to do thrombophilia testing, and I think that's a great place to think very hard. But once you are doing thrombophilia testing, there is some room to think about it. What I would recommend, based just on our study, is if you get a negative result with functional testing, it can be done. We're very, very comfortable saying that the functional result is very good and very concordant with genotypic testing for factor V Leiden for negative results. Genetic medicine societies will suggest that you do a genotypic test, if only because it may allow you to perform better genetic counseling. It is a very marginal use, since the vast majority of patients in our tested population are factor V Leiden. But you could make the argument it might be useful to know if it isn't factor V Leiden, if there's more of a diversity in the factor V mutations in patients you see. But in general, for negative patients, it's going to be the huge bulk of your screened patients. You can stop with the functional test. For a positive patient, I don't doubt the accuracy of the functional test. The medical geneticists may feel that a genetic test is necessary for better counseling. But on the whole, most of the time, just a functional assay will get you the information you're looking for.
Something else as well?
Yeah, unfortunately, my video doesn't restart, so some technical problems. But yeah, in my opinion, for thrombophilia testing after family members who had an event with thrombosis or the pulmonary embolism, in most cases, it would be enough to do functional testing, but as it is at the physician's discretion to order also genetic testing, we have here in Austria no limitations. So it's possible to do functional testing and genetic testing in parallel. So yeah, we are spending quite a lot of money. I mean, but yeah, from the data we have shown, functional assays, as a concerning factor V Leiden, would be accurate and would be enough. And actually, quite a lot of gynecologists are performing or do a testing prior prescription of oral or of contraceptives.
Yeah, so you mean functional testing, basically. Yeah. So when would you actually kind of confirm you're waiting then with the case of homozygote identified with a functional test? Would you then kind of confirm with a genetic test?
I didn't get the whole question, but as far as I understood you, in my opinion, we can properly discriminate between homozygous and heterozygous mutation based on the racial results, which are, as a homozygous, would be below 1.2, and heterozygous would be between 1.4 and about 2.5. So, and this discrimination is really accurate. So actually, there are only a few patients left to test genetically in these so-called gray areas, where you have ratios between 1.2 and 1.4, and in the result area of 2.5 and 3.
Yeah, I guess I could take on to that and say that I talked a bit about the equivocal results that we saw generated by the older PTT-based assay would be a problem that you have to go to genetic testing to determine. But emphasizing again, the vast majority of patients that are getting this testing in our health system are being screened as outpatients with venous thrombophilia, and the nature of screening is such that the vast majority of them are being negative. So most of them will be fine with a functional assay. The very marginal argument would be that if they are positive on the functional assay, you technically don't know what mutation they have. But in our study, over 10 years and 1,600 patients, we found one patient who probably had a non-factor V Leiden factor V mutation, which suggests that the value of doing the additional genetic testing is very marginal. Nonetheless, in our health systems, you will probably see most folks, if they get a positive functional assay for activated protein C resistance, will go to the genetic assay. And that's just because we are maximalist in the way that we try to run these things down. I don't doubt the accuracy of the assay actually being able to discriminate between the two.
Yeah, thank you. Thank you. Yeah, the question was whether basically the algorithm which you elaborated is basically based on the discretion of the individual, done there, or whether there were some like which recommend a certain, like, for example, start with a screening assay, and in case of also finding, you would then do like a patient confirmatory test, whether or not that's really required. So the question was, are there some guidelines on that?
I think I mentioned really briefly earlier that there are definitely lots of guidelines on whether you should do this testing, but there is an extreme dearth of really like ISTH or ASH guidelines on which kind of testing you should be doing. In part because I think it is somewhat true that outside of laboratory medicine, I don't think a lot of folks are super conversant that there are in these different methods. So it may not have risen to that level of concern. But also because of the relative equivalence of the methods. It will come up sometimes, like I said, the American College of Medical Geneticists notes that the phenotypic or the functional tests is an option, but recommends that you go to the genetic test if it's positive. And like I said, that's that esoteric marginal case to be made for it. The other problem that you'll run into, or kind of the clinical dilemma, is that there are different patients that you might treat differently. Somebody of childbearing potential, or is potentially going to go on to have more children, might be more interested in the genetic test because of potential prenatal counseling for that marginal value. If you have, for example, somebody who's out of childbearing potential for any reason, they're probably served just fine by the functional assay, because that tells you more what you need to know about their risks. So it could get, there's lots of interesting edge cases.
Hey, thanks a lot. Check. Do you bring up a question from the audience?
Michael, you're very hard to understand. Should I continue with some of the questions?
I was just asking you, would you like to continue some questions?
Yes, because I think somehow your microphone is not so well, so it's hard to understand it. So maybe I can continue with the question. So this question: how frequent and relevant, from your point of view, are these cases with the false results of the PCR as a result of this stem cell or liver transplantations? So is it really something to worry about, or is it a real rare case where you say, okay, it happens once in a million? Or
Sorry, Dr. Perler, I'm just stealing all the questions.
You told the story of the liver
So-
transplantation. So
Yeah.
it's yours.
Fair question, right? So of the 1,600 cases, we had 4 that were discrepant due to transplantation or transfusion. And that is a reasonable question to ask, especially because, you know, we're University of Washington, a very busy solid organ and hematopoietic stem cell transplant center. It really gets into what patient populations you're screening for thrombophilia. The vast majority of people don't have liver transplants or peripheral stem cell transplants. That being said, it is not a marginal case, not 1 in a million, it's 4 in 1,600. So that's something like 1 in 400. And again, we come into the problem of large numbers. If you are sending a couple of these a year, you may not run into this problem. If you are a reference laboratory, you will run into this decently often. At least a few times over the course of a decade. And it can be really helpful to be able to tell people, because it's more of a 90-10 problem. You spend 90% of your effort on 10% of the things. And a lot of our more in-depth clinical consultations can really be solved with judicious or intelligent use of functional testing like this. So if anything, that's it's a very useful tool to have in your back pocket if you are assessing the thrombosis risk of one of these patients. Not common, but good to have when you got it.
Mm-hmm.
Also, just to mention the story I told, from our data, there is about 1 in 500 heterozygous patients you will find such a condition. There are several other cases we collected. They are unpublished, because I mean the whole story is solved, so the interest is low by journals. But the constellation of pseudo-homozygous and pseudo-wild type results is there, and I mean it has some consequences, at least in young ladies, if they're pseudo-homozygous. You would not put them on oral or on contraceptives, and if they are pseudo-wild type, you actually can prescribe them and put them on contraceptives, because if you would rely on the genetic testing, you would not give a lady with a pseudo wild type constellation the appropriate medicine, and in the other way around too. So there is some indication or some effort to do this. But there are rare cases. Okay, rare cases, of course.
Question which just came in. I had somebody fix my microphone. I hope it's better now.
Yes.
And just a question from which just came in. Having said, or basically also looked at your case with the in Austria, this kind of legal case where a pill or a contraception was prescribed without prior screening. Would you say, or would you vote for a general screening for factor V Leiden mutation prior to prescribing the pill? Or is that something, because that's something I heard in the field, that some of the gynecologists said, yeah, anamnesis, asking the patient about the history of, family history is sufficient? Or would you rather say no, really screening is a good thing and should be recommended in this case?
Naja, it depends on the legal situations in the different countries, I think. Also here in Austria, the judge decided prescribing a contraceptive pill is something similar to a surgery, as a surgery to improve your face. Sorry, I'm just missing I'm missing the proper word. It's something similar to perform surgical procedures, and you have to inform your patient about the risks. So
yeah.
the judge here in Austria decided not to talk about this topic and not to offer the test is an error. So
Interesting. Yeah.
It depends on the way how the let's say the gynecologist sees this problem. I mean, of course, if you offer this test, you also imply that this medication has some risk. And I don't know if this is always the topic people will address, because I mean, you are providing some service, and providing this service, you on one hand say, oh, but there is some risk. This is always a problem. I mean, nobody. If we talk about, because I talked about breaks, I mean, there are certain car makers, because it's easier to talk about this here in this field, nobody addressing. There are certain car makers who did things which all did, but they were put, or they were catched. So it's the question if how you see this, and how you agree with the people addressed. And as I showed, I mean, industry put quite a lot of money to find settlements.
Okay.
And, I mean, I think with this money you could easily test all without any, or most likely testing would have been cheaper.
Yeah, highly interesting topic. I think we are currently running a little bit out of time, and I think that's probably all for questions for today. So may I then hand over to Rose. Again, thanks a lot to the presenters. It was highly interesting, very interesting topic. Thank you.
Thank you, Dr. Janssen. Sorry, Janssen, I just slipped there. My apologies. I also want to thank Drs. Murphy and Pruller for discussing the cost effectiveness and value of phenotypic activated protein C resistance testing for the assessment of risk factor V Leiden mutation in patients with thrombophilia. And thank you to Drs. Glauner and Janssen for contributing to the question and answer period. This webinar was supported by DSM Nutritional Products Limited Branch, Pentafarm, Asch, Switzerland. On behalf of our sponsor and our speakers, thank you for attending this important webinar, and have a good day.